Okay, could we take a seat, please? And we have, I'm very grateful, we have some new members who've attended the hearing. So I'll start on the left-hand side on this occasion. Yeah.
My name is Amy Stevenson. I'm the Centre Manager here at the Earls Health and Wellbeing Centre, and I work for Turning Point.
And my name is Helen McFarlane. I also work for Turning Point, and I am the Head of Research, Engagement and Co-Production, which is a very long title, but it's basically about working in communities to do community-led commissioning and hopefully service change arising from that.
And I'm Marjorie Broughton, and I'm involved with Think Local Act Personal. It's a group of people with multiple difficulties who come together, and we're pushing through, we're funded by the Department of Health, and we're pushing through personalisation, and I'm a personalisation champion.
Thank you.
And my name's Leona Modis. I'm a community heart failure nurse working in central London community healthcare, and I'm also here to represent the Queen's Nursing Institute to give a voice for the nurses who do work in this area. I work in this locality, so I have a good perception, a good understanding of the needs of the local community. I also live and work in London, so I come with a lot of knowledge.
Thank you. Thank you.
I'm Natalie Tyke. I'm here representing, I think, the cancer community. I sit on a number of panels related to the changing of cancer services in London, which includes patient panel, the early detection and awareness panel, and the executive and implementation panel.
My name's Jacob Nash, and I'm Head of Development at the Fulham Football Club Foundation. We're the charitable arm of the professional football club Fulham FC, and we are a physical activity, sport and health education provider.
And I'm Christine Vigers, and I'm Chair of Health Watch Central West London, which covers the 3 boroughs, and I'm also a local resident.
So I think before we start, we are in this health and well-being centre. I just wonder whether we have someone here who could talk about this, and why it's here, and how successful, and Sam, sorry, Amy, yeah, how does this work, and how many of these are in London, and why do you have it here rather than in Paddington?
Okay, so to give a brief history, the centre's been open for just over 2 years now, and it was originally commissioned by the then PCT, the Primary Care Trust, and Kensington and Chelsea Primary Care Trust that was. And the idea of the centre is to have a range of services, clinical and non-clinical, all under one roof. So within the centre we have a GP practice, we have sexual health screening, a dental practice, and we have the services that are run by Turning Point, who I work for, and they're the services that are designed to fit around the clinical services. So it's very much what we've been talking about in supporting people to have something beyond the clinical contacts that they have with their GPs particularly, but also the dentists or any of the services in the building. So an example of that is that we have wellbeing coaching service. So anybody actually in the area can access that service, but that was particularly designed to link with the GP practice so that patients are able to go to a complementary service that allows them to talk about what health issues they have, what they're struggling with around their health, how they may break down the barriers, set some goals to be able to move forward and improve their health. And part of that is not just the one-to-one interaction with that kind of service, but it's also linking with other services that are available in the area. So whether that's physical activity, it could be housing, employment. So coming back to the wider determinants. So that's the wellbeing coaching role, but that's the link that Turning Point has within this building, is to encourage people. We do deliver a range of different activities within the building, so physical activity, creative writing, lots of different activities that are supporting people's physical, emotional health. And I guess the reason for it being within this area, originally it was Kensington and Chelsea focused, although we work tri-borough and beyond with some of the services. But it was to acknowledge and support areas within. Many of us will know that Kensington and Chelsea, in terms of health statistics, comes up very highly if you look at it as a whole. But we also know that there are some areas within Kensington and Chelsea where people are really struggling with their health. And Earls Court is one of those areas within the borough. So it was decided that this would be a good location. But equally, in terms of transport links, it's good for accessibility for other people to come to it. So I've mentioned about the area, and a lot of the services that we cater for are tri-borough or the GP practice, for example, is more localised. But we also have walk-in appointments, so it's a centre that's able to cater for a range of different people, really, and hopefully they come and access this, and then are able to access other services that are going to help them beyond just the GP appointment that they came for.
Thank you. Thank you. Any thoughts about, please, Christine.
Just to add to that, that why Earls Court, that was identified at the time that there was a gap in services in this area and particular needs in this particular area. And there was a period when there was a steering group which was composed of local residents who worked with the Primary Care Trust in order to help with the specification for this centre. So it was very much something that came out of the needs of the locality and had local people involved in the planning.
Yes, Anne.
You set me the challenge of thinking about how we should fund things. So one of the, and Tim started this debate when we were having the previous conversation. So the challenge the health service has got in London is that broadly of the £16 billion that comes in to London to fund healthcare, about 90% of it goes on hospitals at the moment. And we know that in order to drive a lot of the changes you're describing, Amy, that we need to spend more of that money on the sorts of things we were just talking about in terms of prevention for people who are unwell, making sure they don't deteriorate and are able to get healthier. But we also know, given the economic situation, we're not going to get lots more growth into the health budget. So it does mean that we're going to spend that 16 billion in a different way. And often what that means is that we need to talk to patients and carers and the public in London about changes to their health services. And I'm not sure we've got a fantastic record of doing that well, because often you're wanting to move more care out of hospital to fund places like this and the networks around them. And I'd just be interested in people's views about how do we have a better debate with the public, because to implement what Tim was saying, one of the barriers to that is you need to bring care together, and that means taking care from one hospital and care from another hospital and putting it in one place where you'll get better outcomes. But you will have read the papers, you may have had it in your own communities. These are always very lively debates with the public as soon as we start to say we want to change the way your local hospital. But
that needs more front investment to see the returns as well.
Yes.
How do we get that money?
Yeah.
Well, I think going back to what we were saying earlier, that if London set itself to be the capital where people came for the very best healthcare with lowest complications, whether that be in the secondary care sector or indeed in the community, you would attract people from all over the world. They come, they bring their families, they bring investment, they spend money in London, and actually then that allows you to use more of that money outside into the wider community to actually improve the care of Londoners. So sometimes you have to take some radical decisions, and if you explain it, I think, in the right way, as we're trying to do with our project, I think people will buy into it, as will clinicians.
Can I just say, Turning Point recently conducted some research for the West London CCG, and we recruited, using our sort of connected care model, we recruited and supported local people, and for this cohort, it was a cohort of people with long-term health conditions. And this was the aim of the research was to look at information, creating an evidence base to inform the out-of-hospital strategy. So what we did was work with this cohort, people with long-term conditions, and they went out and asked their peers and interviewed them about their use of different services in the community, the voluntary sector, GPs, the hospital, what they valued, and tracked them against their postcodes and their use. So we were able to supply a lot of information, some of which was an evidence base for things that were known anecdotally about why some services were valued. But what was clear was that where a GP practice was offering sort of accelerated appointments for people, and the GP relationship was good, then the use of the acute sector was much reduced. But it was also things like the policy now is more towards self-management, but for a lot of the people that we interviewed, self-management is a challenge, and for many of them they need support to get to the position where they can self-manage. So actually, if you follow without consulting with the community and finding out what are the challenges for them and what support do they need to help them use the services more appropriately, or to manage their conditions in the way that they would like to manage their conditions, then actually you have to provide a different level and a different type of provision. It's not just a one-track route.
Yes, Leon.
Sometimes I feel there's a lack of communication. We're not integrating care. We're talking about secondary care, but there's a lot that happens in the community. And I know from my own service, in a sense, it's very much. I work with a group of people. I work with district nurses, community nurses in the community. I work alongside GPs. And I have to say it like that, I work alongside them, in that whatever happens to the patient in the hospital, a lot of that care can be transferred for nurses in the community to support patients to manage themselves. But it's not a reduction. You're looking at nurses who are qualified, who know how to manage the patients in the community, and often that's misinterpreted, in a sense of how that care can be transferred. And sometimes people don't know what's in the community, and I think we almost need a directory for everyone to know what is available, because I don't know everything that's available, I know, in this locality. So we really need somebody to shout out to say, this is what we can do, this is what is available. It's having an awareness of what exactly, for example, what can the district nurses do, what skills they have to manage that care in the community, so that person can leave hospital at a much earlier time. It's something we facilitate. Transfer of care. He was speaking earlier on about orthopedic, and in my head I was thinking, well, let's try and prevent that fall. If we identify what patients you're likely to meet, can we meet those patients as soon as possible? If it's a case of osteoarthritis, can we manage that better in the community? And then we can teach patients about falls prevention, and we do a lot of work in our area to try and have falls champions, so that, we don't want to give you less work to do, but the idea is to give you less work to do, and manage those patients better in the community. So that's where there's a lot that can happen, but it's just not being used effectively, I think.
Sure. Yes, please.
Yes, I think a lot of this is to do with public confidence.
Yep.
And when people are discharged from hospital, they feel that hospital is the only place that they can be treated. Therefore, you need to do something to sort of give confidence to the public that they can receive excellent care within the community setting. And I would also advocate that perhaps you had sort of project managers to, that the mayor could employ a couple of project managers to put all this in place and to fully integrate all the services and advertise what's happening, so that people then realise, the local papers could carry it. I know some of it can be expensive, but I just feel that people are afraid, and they've got the traditional thoughts about being in hospital, and it's not as good as being in the community, and we need to change this.
Thank you. Yes.
I was
Natalie, and then Christian.
With regard to cancer services, as I mentioned, they're being restructured in London with the past 5 years. And what's happened is they had to overcome a lot of historical boundaries. So now, of all the 31, I think, trusts in London that deal with cancer services, they're involved in only 2 different systems, integrated care systems. And those 2 integrated care systems are also talking to one another. And that's the most important thing. So, for example, they've got colorectal clinicians from one of the ICSs, as they're called, to talk to the same cancer from the other, and they've come up with best practice. And that's the most important thing. They talk to one another, they say, get over their own personal egos as well. And some of the hospitals have said, well, we're going to lose services for the rarer cancers because they're going to be consolidated somewhere else. But the whole idea is that they talk, and they can see that there are new, novel ways of approaching this. And they've got the public involved as well. I think public confidence is very important. Now, you don't want to go to a hospital to be treated for a tumour that they only do once a year. You want to go to one they do 50 a year, or something like that. So it's bringing the public in to see how those changes, those transformations, are for their own benefit as well.
Yes,
At this point. So I think you've hit the nail on the head in those recent. How do we build the public confidence, to rise to Anne's challenge, in the alternative? We all kind of get and know what a hospital does, and we all assume that the expertise in a hospital is something we can rely upon. And the frank fact of the matter is, through A&E, we're not stopped from going into a hospital. We might wait 4 or more hours, but that's it. Some of the confidence issues, therefore, and I just want you to expand upon this point, that we've learnt already are about access. If I can't get access to Leonia for 24 hours, I'm going to go to the A&E department. If I can get access to Leonia in 4 hours, I might come somewhere like here, in a walk-in way, and do that. I don't know Leonia's expertise compared to what I imagine the expertise of, say, a consultant doctor in a hospital would be. So that might make me think, do I want to come here or do I want to go there? Are there any other points like that where confidence, that the public will be really confident about the alternative? What would be your added insights to that?
I would about that with regard to cancer care. For example, if a person's being treated and something happens at home, they're not sure, who should I call? They could either think of going to A&E, or what we're trying to get some advocacy for is to have what they call cancer nurse specialists. So someone who's available 24/7. You can send an email or phone them or something like that. Now, it's very expensive to do something like that, so one of the notions now is perhaps they would have these cancer nurse specialists who would cover a wider area, not necessarily only you, but they would know about this particular tumors. And so you would have someone all the time to contact, and I think that is really important.
I'm going to ask Tim in a minute as well. I mean, you've said peer-to-peer. What have you done with the public?
There's a lot of bad language being used around this table. Acute and community. The work we do, we ban the word community because it implies the hospital is not part of the community. Primary and secondary, one person did say to me, does that mean primary is better than secondary? But these are historical. And I think there's a branding. For example, he's going to make the London Bone and Joint Service or the London Cancer Service, which happens to be in 2 networks. I think London, you've got a great brand already. So we've got to get over this idea that generalists are not so good as specialists. In fact, generalists are very good at complexity. The person with 4 conditions and 8 prescriptions. So there is, we've got communication people here. I think there's a lot to do with the language we use that reinforces the feeling. So you're part of the West London Heart Failure Programme or the West London Healthy Heart Programme because you're also doing prevention. So some thought given to that, and again the Mayor's leadership, he's a very good communicator. So we rebrand it and we stop using 19th century terms like outpatient, acute, community, primary, secondary. Banned. Bad language.
Please, yeah.
Can I respond to that? And I absolutely support what you've said. At the Queen's Nursing Institute, what we have been promoting over the last year is to stop the use of acute and community, because acute describes is one concept and community is another.
You introduced yourself as a community nurse, and I wonder, is she a district nurse or a health visitor?
not labelling myself.
We saw that out
I'll do that outside. And I think this is really important. The hospital is a part of a community, and patients spend the majority of their time in the community, not in the hospital. And the hospital is a service. And so what I'd like to challenge the people around the table with is how can we then how can the Mayor focus his efforts on improving the health of those who are living in the community, we're not going to focus on the hospital right now for my question. So this is about how do we improve that public confidence to know, so that patients know what's available. And Natalie, you spoke about expense, but actually that specialist nurse may well have prevented multiple visits to A&E. So what can be done?
Well, I think that it's really an important issue you brought up, because the Mayor had a program, the London Health Improvement Board, which had 3 different work streams in the past, one of which was cancer. And it went for only 1 year. It's no longer funded. And what they did is that they had local community centres, pop-up stalls, pop-up shops. One of the football clubs Tottenham had a little stall going. And it reached enormous numbers of people who were just passing by as they were going to do their marketing. And they dropped in, and it was friendly, very, warm and fuzzy type of feeling. Tons of literature available. They had nurses involved to talk to. And people just came through. And so the footfall was really quite high. In the end, they did a study. It only cost something like £20,000 for each of these pop-up shops, which is not a heck of a lot of money. And the problem is now that the Mayor has no longer commissioned this, and it goes back to the local boroughs for doing that. And I think 4 or 5 boroughs have been doing that, and they're very welcomed. And something like that, first of all, it gets over the idea that cancer is a bad word. Come and talk. They're called get-to-know shops, get-to-know cancer. So it's just a thing to bring people in, to let them talk, let them discuss their fears about these things. And it's something that the Mayor did do and is dropped.
Yes. Sharing IT, because one way of getting over this idea that if someone is in hospital and they leave the hospital, they're discharged, that somebody in the community is up to speed with what has happened, that event in the hospital. It's that sharing of information, that transfer, which should be seamless, but really isn't all the time. And that's the thing that may build confidence. It's getting people to understand that whatever happens to you, we know about it. Sure. We've known since yesterday. We knew you were in, we knew when you were going, and we're here now that you are back with us. And I don't like using the word, as you said, because I see a lot of acute patients in the community who need acute support, and I manage them acutely so they don't have to go into hospital. So I have the expertise and confidence to manage those situations. But I know a lot of my colleagues may not have that, and I go around to share. I'm sharing that and teaching. So that's how I pass on my knowledge. That's how I'm hoping to gain public confidence and to get more people to buy into what we do in the community. So it's really about, I think, sharing, integrating care much more and being much more transparent about it.
Okay, thank you. Jim, and then...
I just think it's got to be collaboration rather than competition. And I think it has to be clinically driven and clinically led, I'm afraid. I think patients on the whole still have a huge amount of respect for the medical profession and the nursing profession, etc. I've been to trusts where there have been exercises done by management consultants. That doesn't work. And I've been to trusts where there is top-down management and clinicians having little say what's going on. That doesn't work. And if we're going to get through this, and we've got to collaborate, clinicians have got to drive it, and it goes back to Muir's thing about clinical leadership is going to drive this, and that's how you get the public confidence, working very well with the patient associations, I think.
Thank you, Christine, and then Jacob. Oh, sorry, then you.
Yeah, I mean, there are a lot of initiatives going on at the moment, and there's a lot of work being put into developing integrated care. But I think in all of that, the work on communication and actually consulting with the public rather than the lay partners is lagging behind. And so people actually don't know what's happening, and people lack confidence. And as long as they have a habit of going to A&E, that they'll go on. So it's a major piece of work, and it needs funding. You're quite right. I mean, it can't be left as an afterthought. It has to be carried along with all the other work streams and to be properly funded. One example of where this is a much more small example of where it works well is the primary care navigators and the community navigators that are now going into GP practices. They're called different things in different areas, but they sort of are there to hold the hands of older people in particular and find out the services for them and to guide them to what may be a better solution for them. So that's one good small example, but overall I think we need to pay more attention to communications.
Yes.
I wonder what the Commission think and what the Mayor would think about the idea that, because we've spoken a lot, especially in this second session, about hospitals and healthcare and the formal healthcare system. And I wonder how much of this is actually about healthcare system and how much of it is about when somebody ends up at a hospital or in A&E or going to their GP, and how much of it is about instilling confidence in the investment in health long before anybody presents themselves anywhere. And I think that's where we've talked some length already about collaboration and understanding what services are out there and available. But you know, young people that we see and we talk to, and when they're talking about specifically our line of work, which is about physical activity, they talk about things that are nothing to do with healthcare as being barriers to their physical health. For example, about the cost of transport, getting from one place to another to be able to participate in a sport. They talk about housing. They talk about living around areas where there are lots and lots and lots of other peers and parents and role models who aren't particularly healthy. And they talk. We do work in places like hostels where, you know, living next door to somebody who has particular issues can massively affect the positive leap, if you like, of spending an hour and a half with us doing physical activity and sport and healthy eating education. So I think that there is a part of this, and this conversation is absolutely fascinating when we're talking specifically about the healthcare system. There's a big part of this about instilling confidence in people that is nothing to do with the healthcare system at all. And actually, I don't know if that's the most comfortable thing in a room like this to acknowledge.
Yeah.
Good place where I wanted to be. Some of the discussion around the table has been talking about engagement, and if you start engaging and you can sell your messages and you can signpost people, which also can be supplemented through effective use of technology and communication devices there, why not look outside of the health centres and the infrastructure in terms of buildings? I was talking to Meriden, she was saying that a cardiac unit, it won't be the acute bit, but has moved some of the rehab into a sports centre. There's been big overheads in running a building like this, especially in London. Property costs a fortune. Are there partners outside of the health service, whether they are sports clubs or youth centres or schools, where you could start the engagement and signposting process there? And that is part of the engagement, building the confidence, knowing where to find things, while other things are going on in parallel, such as Tim saying, if you've got a large budget in one bit of orthopaedics and that's in hospitals, obviously it's a no-brainer. You want to try and get efficiencies there because that will throw out money elsewhere in the system, but that's going to be a medium-term strategy. So what can you do in the short-term strategy? There's lots of people, such as Fulham Football Club Foundation, doing lots of good stuff. There's another thing you're talking about, fantastic, healthy chefs. Jamie Oliver, love him to death. But if you want to engage kids, it's got to be fun. There are things you can do that are imaginative. I mean, you were talking about... I'll pass on to... But in terms of budget, I think you possibly get quite a lot of value for money short term by looking at linking people. Paying people on, 35 grand a year might not take that much, but no body will have the people to do the link work. So who's going to do the link work? So if you can do budget in the short term, it's the people to help the facilitation, the communication. That's probably where the gap is in the short term. And then looking imaginatively at partners who can bring things to the table, say facilities, to start the engagement process, while parallel you're looking at efficiencies within the system. And I would like to hand to Meriden, because what she talked about is having schools, about your healthy, happy chefs. Because if it isn't fun, people won't engage and they won't change behaviour. But if you engage people in something fun, and Boris is good at selling fun messages as well as serious ones, then you'll start a ball rolling.
Just very briefly, what I was talking to her about is, if you think of child obesity rates, you expect the more deprived areas to have the higher rates. We managed to reduce them substantially in Thanet, which is one of the most deprived parts of Kent. And that was a huge amount of investment in children's centres, community chefs working with families. And the community chefs were fun. And they used to joke and they used to be part of the community. And it actually made a huge difference in how people cooked at home.
And apparently their obesity rates are lower than Tunbridge Wells in the most deprived area.
The suggestions we've had in the evidence gathering is health and well-being should be part of the curriculum in schools.
Yeah. Education.
Should it be GCSE?
Yeah, absolutely. I think the problem actually is the issue, which is that the public aren't the problem. Some patients get institutionalised. All professionals are institutionalised, and they've spent 25 years in the one place, and then Tim turns up, and I think it's a transformation problem. So I would say that the approaches that we're taking, trust the citizens, trust the young people. The challenge that we've got around the table is not the public. The challenge is ourselves.
Exactly. Absolutely.
Yep.
Can I ask a question of you all in terms of trust and handing over power and responsibility to patients? What about open access to records as patients? Yeah. Do you think that would be part of increasing confidence and putting the power back with the patients to make their choices? They can see everything.
Secretary of State's given a commitment to that, and that's one of the priorities of the digital service. The challenge will come in professional colleagues adapting to it, but it's only the patient is constant in the kaleidoscope of healthcare.
Haven't there been experiments showing that people will take their own records around, are less likely to lose them than hospitals are? And a lot of, for example, again in cancer care, you may be seen at 5 different hospitals, and the patient is the only one that's the one who...
I want to finish up with one area where being in this wonderful facility, and I see it's not just health and well-being, and many patients have been here to see their general practitioners, is the variations in the quality of primary care and across London. Beside orthopaedics, primary care also has a significant 80% of care is delivered through primary care. So it's a third of the 20% that Tim leads on. So what thoughts and ideas do you have about primary care and addressing these variations? Yeah, and I know there's a couple of primary care colleagues here who are fantastic, so yeah, please.
I know I'm not at the table, but it's a passion I've got at the moment about, I think CCGs and GPs are very committed to their community. They understand their patients and their community profile. And in local authorities, we love working with them. They're great. And they're very close to elected members in many ways in their values and principles. But right now, it's very unclear what the standards are, what the offer is, what the... So many GPs are going to telephone appointments, they're going to online appointments, booking appointments. I myself was a new patient and went online to book an appointment. I could go on a Saturday and a Sunday. I thought that's great. But actually, the reality in the surgery was very much a Rottweiler receptionist and a gatekeeping and a pushing away. And if I'd been 70 and with dementia, I would have eventually I would have appeared in A&E. And I think we really need to sort out what's the primary care GP, what is the offer from GPs, what's the standard we can expect as a patient in the public. And very recently, people were saying to me, responding back to me and saying, well, GPs are overloaded, they're overworked, and they're becoming swamped. Well, I have huge respect for them and like to work with them as partners, but so are we all in public sector. We're all becoming overloaded and swamped. And workload is not necessarily the answer, is it?
Sure.
I think certainly GPs will need to change as well as the rest of the system. One of the things we're working across London is looking at how we agree what standards general practice should be offering. just at the very start of a launch of a consultation around how long should people expect to have an appointment for, how the number of ways you should be able to access your GP, whether it's through Skype or email or telephone. And we talked about modern technology. We don't use old technology. We don't write letters, or we don't use telephones as well as we should do. So there's a whole range of things we want to do. We're starting that consultation saying, what do you think about what we're offering up as a first draft of standards, so that people understand what they should be getting, and working with CCGs to improve the quality of our colleagues, because clearly they're variable. The quality of general practice is the responsibility of NHS England, but CCGs have a responsibility to improve the quality and want to do that. We want to offer good care to our patients, and we have a real remit to do that. I think the Mayor can help with some of this.
Sure. And first, and then...
I think it was just saying that it's the tension you said in the earlier session is that debate is about one of the reasons when you talk to people why they use A&E, and the biggest growing group of who use A&E is actually people in the age of 20 to 40. It's not frail elderly. And if you talk to those people, it's because the brand across the NHS, but for us in London, is very clear. 24 hours a day, I'll wait 4 hours, and they have a view about, as James says, about all the things that will be at the back of it. So what's behind what Mark's saying is a set of consistent primary care standards across London, so that whether you're in this borough or another borough, you know that's what you're going to be able to access. The question is, where do you get the balance between that and the personalisation and local interaction? So what's common and what's unique to that borough, because you say the populations are very different, and that's the tension that we're trying to manage.
I just wanted to say that if we come back to prevention and health and well-being, then it's looking at things like loneliness and social isolation, and thinking about what we can do about those. And a lot of the work that we at Turning Point do is about building up that community resilience and trying to develop community-led initiatives like time banks and volunteering schemes. And some of that sort of the navigators that we use are people who started as our community researchers. But I think one of the difficulties is that funding that now is not seen necessarily as you have to identify the impact that you're going to make in advance, and the evidence base isn't always easy to get onto. And you have to, you might be commissioned by health, but the savings are coming to social care, or commissioned by social care, and the savings are in, reduced NHS use. And that, in terms of integration, is a real difficulty when you come to organisations like ours who are looking for funding to do a real integrated piece of work.
And if I could just add...
Marjorie, then, and Amy,
okay.
Yes,
on then.
I would just like to say that demonstrates quite well the need for integration, in that you've got several agencies like Age UK who've got a befriending organisation that address social isolation of older people, and there are Turning Point who will perhaps address all different ages, but it's part of the solution. And it should be taken as such. And although I believe that the clinical sort of governance in this would be quite good, you also need something like a project leader to come in to sort of bring everything else together and make it a lot more seamless.
Amy?
And it's just to echo that point, I think, because we've got, and what Helen was saying, because we have a live example of integration within this building. Yeah. And one of the challenges that we've had over the last year with changes within the NHS, and when we're thinking about primary care, is the element of integration, in that the contracts that we each have are all very separate within the building. So the integration often comes down to the individuals that are working within the services, in this case, because the different commissioning systems don't integrate at that level at this point. So it's, just to give that reflection that this is an example of where we've struggled with that. It's possible, and we continue to try and manage that challenge, but it's difficult, and on the ground level it's difficult. There aren't the systems that higher up at this point to support us in doing that, and to support the commissioners as well, perhaps.
James, James and Natalie, briefly last say.
But I was struck on a number of contributions with, I was drawn back to the Olympics, to be honest with you, and some of the early ideas before that. Thinking of how people are mobilising various volunteers and peer support, and we saw that one of the amazing features and real characteristics of the London Olympics was the volunteer force that just mushroomed, 70, 80,000? Both through the main Olympics and the Paralympics. And I knew many people who participated in that programme, had a real buzz, and were really bereft when it came out of it, the sense. Clearly it took a sort of sense of rising to a massive challenge to mobilise that force. The second thing, I think, in terms of re-engineering Londoners' flows through a system, God, we all had to re-engineer our behaviour as the Olympics, but we were prepared to do it because there was a payoff that this amazing thing was going to happen on our patch. We grumbled about it to begin with, but then we got all right behind it. If you could position, as some people, the earlier ideas were suggesting, some major endeavour in which we're going to lift the whole boat for London, you could begin to apply some of that force and some of those things, and you could begin on, for us who are trying to change systems in the ways of getting people to understand and see the way health is delivered differently to the old constructs that Muir was saying we've got to junk in some way, shape or form. The mayor could recast the narrative, in other words. He could be the person who helps us to rebrand it and helps the public to see it very differently to the way that it's been seen before now.
Healthcare Olympics will challenge the other big cities.
Healthcare Olympics.
Healthcare Olympics is good. It's very good.
One last word. It struck me that, for example, the Health Watch committees, which are around, which know their local populations, and they deal with the volunteer services. They also respond to or report back to the local authorities and to NHS. And so they're rather a link. And I think my local one, we did one on discharge from hospital and found that there was a disconnect. And then we went back to the hospital and said, you should have a better discharge policy. So it seems to me if you listen to enough of these community organizations and they are getting their webs out to others, you really can get a sense of what's going on locally.
Fantastic. Thank you.
Thank you.
Could I, on that note, thank everyone here for the ideas, for the debate. A lot to learn, building on the evidence base. And I very much hope that we can re-engage you at some stage, I think around summertime, where some of these proposals will be out for further discussion. At least you'll have something in writing and make a contribution to that. And at the moment we're thinking, if everything goes well, sometime in October. But we've captured all of this, and thanks for your time, thanks for all the ideas and the effort. And please, when we leave today, if you have a wonderful idea in the bath tomorrow, then please email it to me. I'll love to get those. Thank you. Thanks very much.
Thank you.
Thanks.
Sure.